Fine.
Okay. Okay. Well, thank you so much for joining me today. We've got a very special guest who's joining us from London in the UK. Thank you so much, Dr. Steffen Decker, for joining me today.
Thank you so much for the invitation. I think I'm so excited because finally I have someone I can share my passion with, and also I can share maybe the responsibility we have as orthodontists, I think, nowadays. And I'm super excited for this podcast. So let's rock and roll.
This is a topic that I've discussed with a lot of people around the world, and something we do in the clinic here. It's the topic of orthodontics, and there is a whole exploding field that I think a lot of people are a little bit confused about what's happening in the world of orthodontics. And I feel that there needs to be someone that's been in it for a long time to really explain, how they're shifting their practices, maybe sometimes looking at treating people a little bit earlier, kids in particular, but also to the associated problems that seem to present with orthodontic issues, because I feel that orthodontic diagnosis and treatment has been based around cosmetics with its core values. But there's been a recent understanding that there's so much more connected with how we understand how the teeth grow. Dr. Decker, how did you get into this area? You're a specialist orthodontist. When did you first start looking into this area, and how did your practice start to change? Tell us about your background.
So, to be honest, I was German trained, and the fundamental training at universities in Germany is actually on kids and growth and development. Like most of these devices that are out there for a long time, like Bionator, Activator, Schwartz devices, are actually being invented in Germany and Austria. So we are quite confident with the topic of early preventive orthodontics using functional device from an early stage. So I was lucky enough that from the first year of my specialty training in 2008, I went into contact with kids and I used functional devices. And I had also the pleasure to be supported by an amazing boss I worked in a private clinic on, and she was very holistic straight away. So she had an osteopath coming into her clinic every month to align the legs when we took a bite to change a bite in a kid. So I was already quite wondering at that point, like years ago, why does it have impact on the posture and the leg position when we change teeth position? So I found it quite fascinating. And at that time already, no one had talked about it. So basically, after that, I went to Switzerland and I treated a lot of kids with functional devices really successfully. But obviously, they were quite bulky devices and reliant on compliance. And that was sometimes a problem. But in Switzerland, we're on a countryside. Normally, people are very compliant. Then in 2015, I moved to London. And I moved to London, and in London, I realized nobody is treating children. So for a number of years, I treated only adults and with lingual braces, like fixed braces. And I tried to talk to myofunctional therapists, to osteopaths, to speech therapists, but I could not find any. So in whole London, I could not work with anyone I was used to work with in Germany and Switzerland. And I found that at that time very bizarre. And then for some reason, I basically forgot about the whole topic of myofunctional and function around the teeth, because I was so focused on adults and lingual braces that I completely forgot my passion, which is prevention in kids. But then over time, as you are aware, clear aligners pushed onto the market. So at that time, I was very unique because I did everything with inside fixed braces, lingual braces, and I was very successful. But slowly, I got less and less customers because every dentist in London or in UK is offering clear aligners on adults. So the market became very competitive. So therefore, the prices dropped. because the patient didn't know anymore what is the difference between me as a specialist and a normal dentist. So they only seen the price difference. That was very frustrating for me because I worked in different clinics. They had their dentist doing alignment with aligners, and then they covered the teeth with cosmetic bonding. So for me as a specialist, I was left with actually only surgery cases. And imagine coming from a background based on kids with prevention, ending up with only adult surgery cases. It was actually for me depressive. I came home really crying to my wife and saying, why did I study so long just to fix something that cannot be fixed because they don't have the funding to do it? So then what happened? In 2017, I met my wife. And she needed the best orthodontist. She's a restorative dentist, and she employed me as her orthodontist. And the first thing she said to me was, Steffen, have you ever seen your cases that you finished as a child 30 years after? And I said to her, no. Why? I'm number one in the world in lingual incognito braces. I know orthodontics. I'm the best. I'm everything. I move everything into class 1. I'm perfect. But then she showed me failures in adults where we've seen tooth destruction and where. And where did she get that knowledge from? That was from John Coyce in Seattle. So she said to me, Steffen, before you can talk to me and treat with me adult cases, you need to understand my language of prevention and functional occlusion. So you need to go to see John Coyce in Seattle. So I went to John and I did his courses. I became a Coyce specialist. And I asked John, you know, all of these cases we're discussing at your center, they are adults where certain things went wrong. We deal about dental trauma, tooth wear, about GERD, erosion, and all these things. So I asked him, could they have been prevented if we would have had good orthodontics early on in life? And he said to me, I think so. So at that time, that was 2020. I went back and I basically got headhunted by a kids-only clinic, a new clinic in London that opened up, focused on pediatric dentistry. They wanted to have an orthodontic branch and said, Steffen, would you want to join our team? So I said, yes, I love kids. It's a new thing. And then lockdown happened and I had time to actually spend on education and think about what's happening on the market, reflect and talk and think about these aligners. What is these aligners nowadays? What can they do? And what is the problem with them? So I realized, okay, the last few years, I was always a bit apprehensive because I've seen the failures done with aligners, but I realized, okay, they seem to work in the right hands of a good clinician. So then I went back to the kids clinic and I said, okay, I changed now every child treatment from functional and expanders to aligners. And I realized that kids love it. So the kids were so happy. They had no discomfort. They were super compliant. They couldn't wait to change these aligners. So therefore, I had amazing success because from a biomechanical point of view, aligners are super powerful in movements. And we can do much more movements at the same time when we want to. So then I have never, ever treated aligners before in my life. So I became a Diamond Apex user in my first year using aligners, and that is only based on children. So I realized, wow, why is nobody doing this? And then I started go back to my education from the beginning and says, okay, now I'm with kids, let's rock and roll. Let's try to get connections. I need these people in my team again because I know that it's more than just teeth. It's about the tongue posture, it's about tongue function, it's about breathing, it's about lip seal, it's about gut health, it's about posture. You talk about it as well in your podcast. It's so much more than teeth. And don't forget self-esteem of kids growing older. So then basically I found a speech therapist. She was a patient of mine coming for consultation for her child. So I realized she's a speech therapist. I said, yes, I found someone who comes for me with the kids because her child is struggling developing speech because of a narrow palate. So I said, we need to work together because you cannot develop speech without good tongue space. And then she said to me, oh, you need to read the book by Richard Baxter. You need to read the book by James Nestor. So she linked me with Dr. Sagi in LA. So I got my head around, said, okay, wow, this is exciting. Let's dig it deep into it. And now what happened now the last 2 years since we opened our own business from scratch is just insanity. Because in the UK, for some, the NHS system, which is the national health system, is only seeing children above 12 years of age. And from a functional growth and growth perspective, it's absolutely nonsense to treat kids after 12 because the facial development, the growth is completed. So we can't have an impact on it. So me being focused on kids actually below 10 years of age, I have all the opportunities to change a kid's life, to change facial growth and development. And that's what I'm 3D metal printing or the combination of both of them. And that completely changed me because I love my job and I love going to work every day. 5 years ago, I came home being not happy. I was emotional. I cried. I said, why did I study so hard in my life? Now I can't wait to go tomorrow to work, even doing a podcast now at 11 o'clock in UK time. I go tomorrow to work and I love my job because I know there's going to be another child that gets my opinion and they have the choice to make a change for the kid's life. And that is super emotional. That's super satisfying. And that is what you and I are trying to do, to create awareness of the need for early interceptive preventive orthodontics. And yeah.
Thank you so much for sharing that journey, because I think it's important for people to know it's a difficult path. You know, you're talking about, you know, a 10-year journey for a practitioner moving to another country, you know, unlearning your training, which I want to dive into because I think that's important, because this the people that are listening to this are mostly US based, so they mostly are kind of experiencing US trained practitioners, and I think there is a more of a focus of certain European countries to look at functional appliances and early intervention. And you know, you mentioned that you had this trained into you early in Germany, and so I want you. Can you explain that a little bit, how German training looks at this early intervention space in a university sense, and then how you've perceived that to be different from, say, Western trained orthodontists?
The thing is, what I see, it's you know, also to be fun, it's quite funny because even in Germany now, it's we had the training, but still the orthodontists are not doing it anymore because the health system doesn't fund it so well. So they don't get enough financial support from the health system, insurances in Germany. So it seems to be not financially lucrative for an orthodontist to do that. So even in Germany, it seems to me that most focus is on teenagers and adults. And in US and all the other countries, it's the same. The problem we face as orthodontists is now that the adult market is completely dominated in UK by GPs, dentists that do aligners on adults. And to be fair, I know a lot of clinicians, I trained also some of the clinicians, they're becoming really good in aligning teeth with aligners in adults because we have technology, we have scanners, we have AI technology, which supports them in that. And 30% of all teenage cases in the UK are already being treated by a dentist. So our space as orthodontists becomes invaded. So the adults are gone. The teenagers are drifting away from us. What's left? So if an orthodontist nowadays doesn't understand that the market for us gets smaller and smaller and smaller, that we should actually use our knowledge, which should be growth and development of children, because it's so complex that a dentist who does fillings and crowns and veneers will maybe not have the time to dig deep into the knowledge of growth and development. So this is an opportunity we have at orthodontists to actually capture an audience that nobody actually at the moment is catering for. And that is a big mistake because there's such a need. So what I see is universities are focusing on teenage treatment and adult treatment because they say this is the main problem we face within the private practice. But if you ask the right questions and if you do your media presence on social media in the right way, and you actually educate your audience that it's more than teeth. Is your child snoring at night? Is your child stop breathing at night? Does your child has dry lips? If you just educate in a slightly different way, you will see that there's so many parents out there, they have questions. And they go to a professional dentist or orthodontist and says, my child is struggling. I feel it. Please help me. And they're getting told, no, there's nothing we can do right now. Please wait until they are at the age of 12, 13, whatever it is. But the question to me is, if I have children 7, 8, 9, they might get bullied at school because of the appearance of their teeth. So they have a massive impact in their life mentally. Who will be responsible when we don't help these children who are getting bullied at school? When it's just maybe a gap or maybe protruded teeth. If we say to a child, no, we don't help you right now, just get bullied at school. You have to deal with it. I find it very concerning because I know from an evidence point of view, there's a big debate, shall we or shall we not treat early? And we lack in evidence in a lot of things. But what I ask my fellow colleagues out there is, if a patient is coming with a need, like a wish, please help my child, I think it's our duty of care to at least listen, accept that there's a problem, and maybe offer them an option. And if they don't feel comfortable performing that option themselves, then maybe seek out to someone like you or myself who can maybe help them. Whatever tool they choose. It's not about the tool, it's about listening to the need of our children. And I see that every day.
Yeah, I really like that idea. Is that, the practitioner is starting to kind of attune into what the people are experiencing. And, you're talking about market forces and how, practitioners' lives are being changed by what's happening around them with other practitioners and also what patients are doing. But, really kind of tuning into what patients are experiencing, you start to see that, hey, there are people out there that have got this problem and they cannot find a solution for. Tell us a little bit about that for parents that are concerned, or they have an inkling that maybe their child has one of these developmental problems that are affecting the growth of their teeth. What do you see when you see a child walk into your clinic in terms of presentation?
So when I train people in my program, also patients, they ask me all the time, how do you know everything you just said in the first 5 minutes? And the skill that we have to develop is to use our eyes. Because we are so pushed into dogmatic thinking, we need to do X, Y, Z in that order and talk about orthodontic terminologies, which actually does matter to a patient. But if you look at the patient, for example, a patient is sitting on the chair in the waiting room with their mouth open and dry lips. I know immediately, and where they're hibbling around very hyper, can't sit down for 5 seconds, I know already that they are most likely a mouth breather. So then I have the choice. I sit them down. I could say, okay, let's talk orthodontics. This is an angle class 2, diff 1, and they're gone. Boom. Generation Alpha, Z, gone. They can concentrate for 8 seconds. So we need to actually get their attention. So I might start with the question, how is your child sleeping? Then he said, they already get perplexed. They're snoring. They're snoring. And how about infections, tonsils, adenoids, ears, chest? Oh, yeah, all the time. Pain in your ears. Yeah, they can't swim. So then I asked certain questions. I have not even talked about a single tooth, by the way. So I asked straight away the right question where parents get confused. They said, what's happening with me? Because he's asked me questions I always ask other GPs before. So depending what is, and sometimes we might have even parents who are a bit sitting on the fence who says, no, my child is okay, is concentrating well, is sleeping well. And then you need to dig deeper. Yeah. You need to say, oh, is there bad breath? Is there bedwetting? So you with more knowledge you have, you can ask different questions. And then eventually you get there. And then you take an intraoral scanner and you take this scan of the mouth and the kids look up, oh, what's this? And I have a big 455 touchscreen next to my chair. So the scanner is automatically on my touchscreen. So full vision in the patient and parent's face. They look at it and say, what is this? These are your child's teeth. And then you can draw on it. I have a touch screen. I can draw with them. Look, this is a V shape. This is a U shape. They don't fit together. A V shape is a sign for mouth breathing because the tongue is not sitting in the upper jaw. So I asked the child, where's your tongue right now? And the kid will say to me, in the lower, is that not where it should be? So then they're getting confused. What is he saying? Then we do some tongue exercises. Let them lick their lips, let them suck their tongue. And so we do some myofunction exercise in a playful way. And then I normally see the problem very quickly that there might be tongue tie. So now I continue with my questions. How was breastfeeding for you? Oh, disaster. How was speech development? So the people that get confused and they say to me very frequently, they're getting emotional because they said, hold on a minute. So then it's my job is now to link. This is the link between mouth breathing and infections and arch shape and tongue posture. So this is the skill I have to have as an orthodontist to link the dots, to make them aware in a language they understand. And then they get it. And then I just start talking about teeth. Look, a U doesn't fit in a V. Therefore, you get crowding in the lower jaw and your lower jaw falls back. When your lower jaw falls back, you need to push your head forward to open the airway. You get neck pain. Oh yeah, I'm going to an osteopath all the time. So they're just getting completely overwhelmed. Because then I might say to him, look, how's your child waking up in the morning? Is he tired? Yeah, very. How's your concentration at school? Oh, very poor. And I say, some teachers might call that ADHD. Oh, yeah, we were tested for that already. So then I say, what is happening? And I hardly ever talked about teeth. I say to all of my patients, the teeth are a symptom. If you look at the face, because it's much more we see in the face, you ask me about what I look out in a kid. We have the eyes. Look in a child's face. The eyes. Are they sparkly? Are they tired? Are they flat? No cheeks. Yeah. Are they backwards developed? Vertical height. Backwards development. So there's certain face features we see as clinicians, which tell us there's something not quite right. And interestingly, you did also once a story or a post about mewing. So mewing, as a lot of people will be aware, is Mike Mew and John Mew. They are quite close to me here in London. Yeah. So now I ask sometimes the kids, do you know what mewing is? And the kids say, yeah, I know. they start making the exercises. And the parents sit there and said, what is happening here? My kid knows what he's talking about. I have no idea what he's talking about. So then I start explaining to them what it's about tongue posture, lip seal. So the parents getting really engaged into this. And the most important thing I tell my students as well is you need to create value. Your job is to show them what is the problem. And when you created enough emotion that you know they understood the problem, you shut up. Because it's no point you going one by one on sleeping and this problem, because they will feel really bad, because for years they're looking for solutions. And you come in a few minutes, bam, 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 and tell them their life. And the same is for adults. I give you, because where it gets really emotional for me is when I see adults, like I give you a classic example today. This afternoon, I had an adult coming to me. He was only biting in the front teeth with one point of contact. So he was tongue-tied. So I checked his scan. He had erosions on his teeth, acid reflux. So I said to him, you have reflux, don't you? How do you know? I see it in your teeth. How is your sleep? I sleep 3-4 hours max. And I take medication for it, ADHD medication. And I take antidepressants. And I drink in the evening to fall asleep. So I said to him, your bite right now is not your problem. You're tongue-tied, your tongue needs to be up, you need to see myofunctional therapy, we need to get your breathing going, because otherwise you will not be here on this earth, maybe in 10 years' time if you go down that pathway. And he got emotional, said, I've seen a lot of clinicians before you. Yeah, you said to me everything but teeth. You said to me what's going on with my health in my life. So what do I need to do? I said, I'm not the right guy for you right now. You come back when it's the right time for you, when we sorted the rest out. And he really laughed and said, you are incredible. I didn't make any money, but it's not about that. I told him what I have seen. I used my diagnostics and I have the same with kids. And you will see when you do this kind of diagnostics in your chair on a child, the parent is sitting in the corner doing with the child the exercises. And they say, hold on a minute, Steffen, can I ask you a question? My husband is snoring. My husband is doing that. Can you please see him as well? And that is the point where I can say yes or no. Because when you treat a lot of adults, which I did, sometimes you just can't help them because they are emotionally and so involved in it already that it's really hard to treat their psychology. You can treat their teeth, but not the psychology. In kids, they can treat what I'm meant to treat, which is the jaw, the bone, the teeth, and I help them. That's why I'm so passionate about it, because I can just do my job and I know I'm going to help them. And I know they will bring their brothers and sisters, their cousins, and the parents are coming to me as well. So it's a different way, but the most skill we need to develop is to not just focus on problems and symptoms we see in teenagers and adults, because it gets really complex when we treat adults and airway problems and things, because it's just really, really tricky. But in kids, you just need to ask questions. It's not about you in that consultation. It's about the child and how are they doing in their life. Are they doing well? Are they concentrating? Are they behaving well? Are they confident? Are they smiling a lot? Or asking just a question to a child, how can I help you today? Do you have a concern?
No, you describe very well the continuum that is, that a lot of people are really experiencing today. And what you're describing is in adolescents and adults, these people are experiencing these problems, such as breathing and sleep and snoring problems that are, spilling over into, their other areas of life, concentration, sometimes mental health. But then what we're seeing is that if we identify it early enough, that there is a growth and development problem that is at the root cause here that can help these problems from, stop them basically from being so tied up, because you're saying that this is hard to treat in adults, which is true. This is a much harder problem to treat in adults. In kids, when you hit them in this developmental stage, and you're talking, from roughly between 7 to 12, then you're getting early. That's right, yeah. And we're getting them before all these problems become these hard issues, because hard tissues and skeletal problems, they become very difficult to change after 12. And I'd like you to explain that a little bit, because I think from your an orthodontist perspective, it's important to show what this early intervention actual window is. But in terms of, because we talked about evidence, and you're a specialist, and I know that you're guided by evidence, and I know some of the criticisms in this area are that we don't have enough evidence as such to kind of to put treatments or to to enact these kind of modalities as yet. But there is a lot of evidence out there as to what the problems and the associated connections between developmental issues and breathing problems and so forth, and how the skeletal system is potentially linking that. Tell us about some of the key papers that really kind of shifted your mind, because I know you were looking for some kind of evidence there before you would shift your practice. What were some of the areas of evidence that really kind of,
I think for me, the most important thing is, when I train now people, I go back to my university time where I looked at things we learned 15, 20 years ago, and I think about a graph and rethink what kind of impact does it have on my life. For example, if we look at growth and development of the brain grows the first 3 years the most. What does a brain need to grow? Oxygen. And the brain, the skull, the cranial base, is one of the main pushers for maxilla forward. The main problem we have with airway is maxilla. So, when in the first 3 years of a child's life, they're not getting enough oxygen, maybe they're tongue-tied, or even already if a woman is pregnant and she has problems with breathing. So the baby in the tummy doesn't get enough oxygen to develop in the tummy. So it starts very early. So they're born, the brain doesn't develop, the connections are not maybe going so well. So gray matter, there's evidence there, that gray matter loss when oxygen is deprived. So, but the brain size is shaping our cranial base. The cranial base is responsible for primary displacement of the maxilla. Number one. After that, we have a palatal suture that is the growth center of the maxilla. And the suture is fusing. And the suture is fusing with this is all evidence at around 11, 12. And the suture is a growth center for which we can stimulate. So from 5 till 12, we can stimulate a growth center in the maxilla. But nobody's doing it. They come at 12. So at 12, when we want to do that on a suture, we might need to consider to place some mini screws. It gets already quite complex. In young children, we don't need any of that. We can go to the teeth. So by opening and closing this palatal suture, we're creating growth stimulus, and we can either just expand or we can protract. The mandible is growing much longer and later. So when we protract the maxilla first, in early stages of the phase 1, the lower jaw has more likelihood then to catch up because we have more time. With the upper, we don't have time. We are running out of time. So, but when we then advance the lower jaw with, for example, aligners and mandibular advancement, which is new features, which is like a twin block, which works really well in children because it's comfortable, we open the airway. we opened the nasal structure by widening the palate. We might have protracted the maxillary bone to open the back of our airway. And we might have protracted the lower jaw later on in life to open more of the airway. But of course, everyone who talks about airway understands that just doing one thing doesn't mean we can solve airway problems. Because airway is complex. We have conchae nasale, we have allergies, we have muscle structures. So it's really complex, the whole airway system. So the bone increase, the size of the bone structure will increase the permeability of airflow through your nose. And quite often that helps. But when you look at Dr. Sagi's research, he has 6 parameters he looks at. Yeah, mouth breathing, mentalis strain, tonsil, ankyclosia, dental arches, and grinding. We as dentists can address 3-4 things of that with our team. So even if by Dr. Sagi's classification, the fairest 6, the 6 flags, red flags, we have 6 red flags in a child. So severe risk for pediatric sleeping disorder. If we address the tongue space, if we make the lips sealed and we engage nasal breathing with our team myofunctionally, we do tongue tie exercise, eventually a tongue tie release with our team, yeah, we can sort out 3-4 of these 6 red flags. Hence, we expect an improvement. It might be more complex and we might need to refer to an ear, nose, and throat doctor to check the adenoids and tonsils and everything else. I totally agree, but we can help. And preventive orthodontists, I'm not in my surgery saying to my patients, I'm a magician, I will help your child completely. But what I'm very transparent and honest, I said, I'm very confident I can improve things for your child. But we might need to consider to have more people in our team to get there. And they understand it. So if you know that also the lymphoid system grows much more the first 6 years than our structural bone structure, then we understand why the main reason for pediatric sleeping disorder in early stages is the adenoids and tonsils. So maybe the first stage of prevention could be a removal of them. But later on in life, after 6, it could be the tongue position, or it could be that we're gaining weight. Other problems have more impact than the adenoids and tonsils, and that's where ENTs will tell you they outgrow their problem. So we can wait, watchful waiting, because they will outgrow it. Yes, they might, but again, who will be responsible for these years in between where a kid is struggling to sleep? Hence, they're not concentrating. Hence, they are struggling at school. Hence, the whole family might suffer in that. So these things we learned in our fundamental basic orthodontic knowledge, if you rethink and think in which stage of a child's life is what developing, we know what we have to treat first, where we're running out of time. We understand how important it is to breathe for development. And considering evidence, I think the best evidence is, for me as a clinician, is to ask a mom and a dad, how are you? How are you feeling after I corrected a crossbite? How are you breathing better? And if you ask the kid, and the kid is telling you, I am concentrating better, I have no night terrors any longer, I can speak better, I eat better, I behave better, then you have for yourself evidence, because you hear it a lot. And yes, it's not clinical trials because it's hard to get, but the emotionally, I always think about, if your little princess, your daughter at this age is struggling, and you seek help as a dad, which is a very emotional, it's your princess, and you tell them this, we could help her by doing small intervention, and then you do help her, how do the parents feel? How do you feel as a dad? You will be forever grateful to that clinician who listened, with 2 ears, only spoke with one mouth, and looked with 2 eyes. What is the problem? So, yes, we need to understand really well growth and development, to understand what can we manipulate and what not. How can we stimulate growth? What tools do we have to do that? But evidence comes a lot from asking questions. How do our patients feel? And when a parent has already, like, remember at the beginning when I said, my wife said to me, have you ever seen your cases 30 years later? These parents have experienced symptoms for 30 years. So you tell their child can experience these and these symptoms. The parent are listening and saying, hold on a minute, I have these symptoms for 30 years. You're telling me now that I was the same. I said, most likely, yes. Show me your teeth when you were a child. And then you go back and says, this is your daughter. You're the mother. You're identical. And then they think, wow, what is happening? And now I can show cases where I have treated the whole family from 7 to 50 with all the same problem, but the adult has received normal care with extractions and they experience the symptoms, and we need to perform maxillary surgery to fix him, and investment of £60,000. A kid, I did a palatal expansion with protraction. We spent maybe £3,000. Kid is treated correctly, finished. The adult, £60,000 later, is also fixed. This is the dimension we are talking about. So, yes, evidence. I mean, Audrey One in LA does an amazing job with research, and there are people in US much better than in Europe who collect the evidence. Dr. Surusagi all the time. So there's more and more coming in that space, but we need to be a bit patient in getting more and more evidence. But what I ask clinicians to do is to listen more to what are the concerns of our children.
I think you define it very well, though, because you describe some fundamental teachings that you had as an orthodontic specialist about how the cranio-facial base grows and how it directs the growth of the maxilla forward and how it's run on oxygen. Now, we have good evidence that low oxygen states, in both pregnancy but also in sleep states in kids, will affect that gray matter growth in the brain. And so we know as a clinician that if a kid does not have enough oxygen in their brain, they're going to affect the amount of brain cells that are forming and so forth. We have that evidence, and as you say, as an orthodontist, you understand that brain matter also directs the growth of the maxilla. So I think that's a really nice summary of what we know fundamentally, because you're also describing a very complex clinical assessment, that you're adding up all of your clinical, specialist clinical training, which is very extensive, and you're bringing it all to the front to really understand what that patient is experiencing, what their symptoms are, but then to understand that, hey, this patient is not breathing well at night. I understand that their cranial base is going to direct how their jaw will grow, and that if they're not breathing at night, I know that their brain isn't going to develop as well. They're showing symptoms of that. If we can develop that, that's going to, improve this whole system. And then, potentially, without, trying to make claims, but maybe there are symptoms connected, like they are on some kind of medication for concentration or sleep or so forth. So, I mean, I think like the way that you are bringing it, because you have a very extensive background, shows us that there's a very broad evidence span. We don't exactly have clinical trials to show how this treatment and how the treatment we enact exactly affects kids, but that's to come, because as you say, this is something that is quite new. The understanding, people like yourself that has put all this together, is quite new. And even though there is a university training history of early intervention, it has been lost. You've described exactly how it has been lost. You went to London, you were trained in this, it was lost because economic forces and healthcare systems make us practice in a certain way, but a lot of practitioners who understand this aren't doing this anymore. And so this is a problem that we know that is out there, that people are both kids and parents are experiencing, and that we have the tools to do it, and it's a matter of finding those steps to move forward. So I think it makes complete sense in what you're saying. And you know, there are people over at Stanford, Dr. Zaghi, who is an ear, nose, and throat surgeon that you reference quite well, and he's looking at how the tongue, which is a really hard area too. How do you pull evidence together for how such a complex system works? He's doing it, but it takes time. He's been doing it for some time as well. So I really like the way that you describe that clinical assessment and how it really draws on all of your years of training. So, I mean, I'd like to jump into some of the techniques and some of the results that you're seeing. So you are doing this early assessment, and you're using mainly clear aligners now. So what do you? I mean, you've told us a little bit about how some of the kids are experiencing some of the changes, but what do you see when you open up these maxillas, and what are generally your treatment plans looking like?
So number one, when it comes to bone expansion, I don't use clear liners. And we have to be really clear, because I don't want to claim that clear liners will make bone changes. Clear liners is a dental arch change. So also Invisalign recently launched now the Invisalign palatal expansion, and they're claiming to open the palatal suture, but that is to be proven. It's very early stages now. So I use nowadays with printing technologies, you can also print metal, and you can design devices in metal however you want, which is the beauty of our profession. Like I do expansion for 20 years with rapid palatal expansion. But before that, we had to separate teeth, bring it to the lab, put it in the alginate impression. So it was very complex, very basic, not a nice experience for children. Now with 3D metal printing, we can do that all. We do everything in the first session, and then I can design it and fit it with the next session. Then we have remote monitoring devices, which means it allows me to see patients from all over the world. They come to me for fitting. That's it. Consultation remotely and fitting. We need to scan. So within 3, 4, 5 visits, I can treat them, which is already very different. So the first step is always what I do in my treatment plan is, what is the main priority? It can be for a child, for example, I have a gap. They call me a slot machine. I get bullied. Okay, Mrs. Jones or Peter, you have a gap. I understand that is your main concern. Let's close the gap first. Because when I close that gap, you are happy. I can do whatever I want after. And to close a gap with some aligners is the easiest orthodontic tool movement I can have. But I made the patient happy. That was an easy example. Easy movement. But sometimes we have a kid with protruding teeth. So then evidence shows us, especially in boys, we have a very high risk for trauma. And I live in the UK, rugby, cricket, contact sports. Every month we have kids coming to our office with trauma. So I tell them, evidence research shows a bit debate. Shall we treat early? Shall we not? But when it comes to the trauma risk, there's no discussion. Yes, there's a high risk for trauma. We can minimize the risk for trauma by expanding and reclining these front teeth with some aligners. Very easy biomechanical movement. It's called pearl necklace, expand, retract, easy. Patient is happy. We minimize the risk for trauma. Good. So now we're getting a bit more complex. That's the easy thing we can do with aligners. Aligners is a beautiful tool. At the moment, there are 2 companies out there who focus on children, which is Invisalign with their first product range. And we have Angel Aligner, which is a new company approaching to the market with the Kit 1 product. We have also some other functional features, actually, like a tongue shield, habit breaker. So they're very interesting on the market. A bit competition helps. But anyway, let's not talk about the brands and of companies. But so now we get more complex. So now I have a kit where I see a very high palate and a crossbite, only a transverse problem. So I know now this is a bone problem, not a tooth problem. And because of the narrow palate, we have a narrow nasal cavity. Hence, I need to ask my questions. How's your sleep? How's everything else? So I get my answers. So then I have already such a high value because they understand, okay, my child is snoring because eventually the tongue sits slow and so on. Let's widen the palate because there is a crossbite, and that crossbite is causing eventually a shift of the lower jaw to the side of the crossbite, which is very clearly an asymmetric situation. So your little princess, Lily, has an asymmetric face because of the way she bites. Every parent will see that. So they understand it's a bone-related problem. And maybe as a nice side effect of widening the bone structure, we get better air through our nose. Maybe. We don't want to claim here now. But we focus on orthodontics. There's a palate, a crossbite. So we do with 3D metal printing. We turn every third day or something like this in young children. We slowly widening the palatal structure. We opening a gap. We have created space for teeth to erupt because generally we have no space for teeth. They're delayed in their eruption. So we're correcting the bite within 4 to 6 weeks. The bone structure is now big. So my friend Dovi Breo from Beverly Hills always talks about the house. So now we created a big foundation, and now we can build a big house on top. But without a big foundation, we can't build a house, or nothing fits in the house. So, but now let's go one step further. Now we have a crossbite and a class 3. So now we know, oh my goodness, the midface is completely underdeveloped. So we have not only a transverse problem, bone problem, we also have a sagittal problem. So now we need to talk about expansion with the rapid maxillary expander, and on top of it, a night face mask to protract. So within the younger the patients, the quicker you get that corrected. So 6 is much quicker than 8. 8 is much quicker than 10. 10 is much quicker than 12. So the earlier you catch it, the quicker you will correct that problem. So within, let's say, 6 to 8 weeks, you corrected the visible problem for Lily, the princess, and the parents are over the moon. So now you have a good foundation for your house, and now you say to the parents, I have now all the time in the world to build my house because I have space. The teeth, we let the teeth come in, and then we can choose whatever tool we want to make the teeth fit in, to align them. And for me, for kids under 11, it's an aligner because it's comfortable, it's discreet, they can decorate it with stickers, it's cool, it's the parents have it anyway because everyone nowadays wears a Invisalign. We can remote monitor it. So it's super comfortable. If they lose it, no problem, we go to next. If they break it, no problem, we go to next. Nothing can happen. The worst thing that can happen is we need a new scan. That is it. They can eat with it. Their kids eat with it. My kids have eaten crisp with them. No problem. They lose it in the bag. There is on the toilet, on the table, everywhere. But that's the fun of it. We're treating children. It's not the end of the world. So,
and you mentioned you have children 7, 8, 9, and so you're treating your own children this way, yeah?
The first patients I treated ever with clear lines were my children. The first children I taped their mouth were my children. And my children coming now with the tape and says, Daddy, can you cut it for me? They're taping themselves.
That's
my
great.
son is very allergic. He sleeps better. I wouldn't do that and say that to my patient if I wouldn't believe it. My son sleeps better. I lost my twin. I have twins for meningitis at 6 months nearly in my arms. He had tonsil infections every 2 weeks in the first year of his life. So I was in hospital the first year of his life consistently. I have my own story, and like most of us, we have our story why we dived into this topic. Because when it comes to your children, it becomes super emotional. So, my classic treatment plan for phase one is 3D metal printing to correct bone problems in combination or without with masks. And then afterwards, or sometimes on top of the device, an aligner. Because for me, the future of orthodontics is to do bone movement while I move the teeth simultaneously. Hybrid approach. Aligners and 3D metal printing in the same visit. Because you can plan everything very exactly. So imagine when I correct severe crowding and class 3 and crossbite within 6 months. Imagine the efficiency you're talking about. Imagine the feedback you're going to get as an orthodontist. And you think you will have no business, you think wrong. Because when this spreads around the word that you're helping children in a very short period of time, in a very comfortable way, you will be a rock star in your community. And not only your community, when we wrote our business plan, we calculated we had 25,000 children within 5 miles radius. We're seeing patients from Hong Kong, Norway, Sweden, Portugal. They're flying in to us. So our radius is so big that I can't even expect it. This is super overwhelming because that's actually not what I want. That's why I want to do podcasts, because I want to find a colleague in every major city. Who is it at? And what I want to say also is, Steffen, you're a dentist. You're super passionate about this. You might have asked in the past an orthodontist in your community, will you work together with me on the children, help these children? You are the orthodontist. And you have been told, no, I don't see children. And this happens everywhere. Dentists, pediatric dentists, are reaching out to orthodontists and they're getting told, no, I don't see children. Therefore, you're left with either ignored, like I forgot about it, I unlearned what I've learned because I had to live, or you have to think, how can I learn this myself? Because I still want to help these children. And this is the dilemma I'm in. I'm a specialist. I want to protect our profession. But in my personal opinion is, if we are not careful, this market is drifting away because it's our job. We should have the education from our university to treat children. We should understand growth and development. If we don't, who does? I think this is really important to me.
I mean, I think it's an excellent point because, orthodontists are extremely well trained, specialist professionals, and they have a knowledge set there that is just so important to the human population. There are so many people out there that are experiencing this. So, I mean, I think you put it very well, is that, I think people go out there and that there are business forces and that there are systems out there that we kind of get pushed into. And, sometimes it's easy to maybe ignore or forget that there is a problem out there in society that we have to think about. So, I mean, I think that's a good way to put it, is that, that orthodontists are very important people that have a knowledge set that can really help people. How do we kind of get this to become a wider spread phenomenon? Like yourself, you're booking patients all over the world. And, this is something that I believe that the human population is going to experience more, and we need the solutions. So, thank you so much, Dr. Decker, for doing all the work that you have and doing, the self-exploration, but also to the professional inquiry to actually expand your practice to help people like this. It is truly inspiring and something that I believe that is really important for people out there. Where can people find you to come and visit you and find you online?
So I called myself the orthodontic specialist.co.uk. And the reason why is because I wanted people to understand who I am. I am the orthodontic specialist. So I should be the one you should trust for your child, because I should be the expert in this. I'm not a dentist who has a passion for orthodontics. I'm an orthodontic specialist. So you find me on the orthodontic specialist. That's also my Instagram. And I want to just one point from development point of view for companies. If we want to drive this area further, we need expertise from experts in the field, because the companies need our feedback to develop products further to help more children. So we play a crucial part. So my passion is education. We have also courses with our Orthodontic Specialist Academy. So I want to train pediatric dentists, dentists who have a passion in kids, orthodontists who want to learn more about this. This is what I want to do. I want to spread the word like you, Steffen. Thank you so much. You're an amazing guy. You spread the word. You're doing great. I love it. It's so important that we do that together. So I really, really appreciate for what you have done today with me, and I hope we could learn a bit something.
We learned a lot, Dr. Decker. There's no question about that. Thank you so much for joining us today, and I'm sure this won't be the last conversation we have about this, because it's such an important area. It's been inspirational. Dr. Decker, the orthodontic specialist, we'll have to talk soon. Thank you very much.
Thanks, everyone. Bye.